guys, this is Ms. Motley here. We're going to talk about central lines, care, maintenance, and a dressing change. So first what I want to do is to talk to you about the types of lines that we have here. This line in particular is what we consider a triple lumen central line, and this one's located in the right jugular central line. It has a proximal port, a medial port, and a distal port. One thing I want to point out with this particular line is you have clamps here. These are necessary because this particular line does not have an end cap. So what that means is that these lines are open to air and also allowing any blood flow from this jugular vein to pump out here. So if this were a true live person, we'd have blood pouring out everywhere, which is a huge liability and a safety concern. So you're going to see that you have end caps that can be removable, and they are Luer lock as well to access your syringes, IV tubes, etc. One thing that you can do is with this particular type of end cap, it's called a Mel adapter. This particular line, if removed, means that you have to use your blue clamp here. So I'm just showing you this to kind of give you all the ins and outs of how this will look. These are predominantly used in most healthcare facilities. They obviously may have different colors for their tubes, but keep in mind, if this is ever removed, this is a sterile procedure. You need to use sterile technique, not touching the end cap here or touching the end cap here, and replacing that. And we'll talk a little bit about how to do that. May see different colors for proximal, medial, and distal, but that's just the overview of a central line. This is considered a triple lumen central line. You may see lines that are a double lumen that only have your two lumens here, function just the same. This is in the jugular, or if it's even here, they consider this the SVC, superior vena cava area, and these are centrally located to your heart. Okay, this is a Groshon catheter. These are probably less utilized frequently. I do see these in oncology practice, but very rarely. But it is in the superior vena cava, and it will look like this, and these are not sutured. So the dressing care here is very important. It has a clamp and it has one lumen for the Groshon. Another area to look at is over here. You can kind of see this port here. This is a life port. I'm going to remove the skin flap of this patient's chest for you to see that this is a life port or port. This little area is what you would access on the patient with a needle. You have to have special certification to do this. However, once this is accessed externally with a needle, we'll go over this some more in oncology. Once it's accessed, it functions predominantly as a central line. So the student nurse or regular RN is completely capable and prepared to care for it. It's just the insertion of it has to have a special credential. And we'll talk about it further. But I want you to know, when you're assessing a patient and you happen to see this, don't get this confused with a defibrillator. It's appropriate to ask your patient, is this a life port or do you have an implanted pacemaker or defibrillator? You want to ask the difference before you assess any further, but you will see, you can see it up under the skin here. We'll go into more detail there. But first, when we're looking at central lines, we want to assess for the insertion site. So of course this, you don't see there's any sutures into here. Sometimes immediately when put in by the surgeon, this is not a nursing scope of practice to insert a central line. They will sometimes have sutures and these little dots here, and then sometimes not. They also have what's called a stat lock on those. So just want you to see that. So we're going to perform a sterile dressing change for this patient. So what I'm going to do is do that procedure and show you how to clean and how to do that. So first of all, I'm going to inspect my side. It looks really good, really clean. I'm going to have my wall gloves ready. I'm going to get my table in a good fashion. For sterile technique, this bed does not raise, but I would have it at waist high so that I know I'm working at a proper level to not, see my patient slides, working at a proper level so I'm not doing bad technique. So first I'm going to go ahead and get my kit open, and what you'll find in your kit is there are sterile gloves and a mask. Some hospital facilities do require that a patient also don a mask during this, and usually you want to have them turn their head in the opposite direction so that they're not breathing, coughing, potential spitting onto the patient, but place a mask and have them place a mask and turn their head. Then you can go ahead and get your kit ready. I'm going to set this over here and my wall cloth Okay, so I'm going to go ahead and open. Actually, I'm going to go ahead and put on my wall gloves. So these are non-sterile, just regular wall gloves. I'm going to open my kit. Being very careful to maintain sterility. I do love these prepackaged kits here. And I'm going to place my sterile gloves over here, and I'm going to show you this little trick to do. So I'm going to keep my body looking at my patient all the time. So I got my wall gloves on, my sterile gloves are over here. Now I'm going to remove my dirty dressing. So I'm going to remove the dressing in the direction of the insertion site. You never want to pull away because, like we mentioned, there are no sutures here. So if you pull that dressing away, what could you pull out? The line itself, and that would be bad news bears, right? So we're going to pull in the direction of the insertion site, being very careful not to get our fingers anywhere near the insertion site. See how I'm holding back here, I'm keeping my fingers away, and I'm gonna tell my patient to lay really still while I prepare to clean his site. I'm going to remove my wall gloves. Now I'm gonna keep my patient in view because, hey, Mr. Jones, really don't need you to cough or anything right now. Just keep your head turned. I'm gonna be right here so I can see you and see my stuff. I'm gonna prepare to don my sterile gloves. So I really like this setup. You don't have to do it this way. This is just my way, but this way I kind of have everything all together. So I'm going to don my sterile gloves. Okay, come back over here. And the first thing I want to do is I'm going to keep this hand sterile. So you see I'm going to do kind of a jazz hand over here so I can keep this hand in full view at all times. I'm going to use my dominant hand to do all the work until I'm ready to use my non-dominant hand. So the first thing you'll see in your pack, you're going to have lots of goodies over here. You've got a perforated gauze, or bifurcated gauze, talk different things. You notice the difference between it and a standard gauze. This has fibers, this does not. This is appropriate to place on this line because those fibers can't get into the insertion site at all. This is used predominantly for cleaning. The only reason that you should need to use this is if this line is draining. And if it were to drain, you would need to change this particular gauze every 24 hours. Whereas most of the time, these dressings can stay on the patient for about 5 to 7 days, pending hospital policy. But if this is on the patient, you should know an assessment that that's probably going to need to be changed in 24 hours. There's another gauze. There's, of course, your label. Tape. This has swab sticks. These are considered alcohol, but I will tell you that some kits that some hospital facilities have is what's called a skin prep. And the skin prep should not be used to clean the insertion site. The skin prep is used to prep the skin around where you want your dressing to sit to keep that from getting irritated, but also to get a nice tight occlusive seal, which is what we want. So first, I'm going to pretend that this is alcohol, okay? There are 3 swabs in here. For the purpose of my kit, I'm not gonna open them, but I'm gonna pretend. But I would come and I would start with alcohol, with the swab, and I'm gonna open it, because it's better to see that. So, let's sit right here. I'm going to start, here's my jazz hand. I'm actually going to clean and touch the insertion site, okay? That's the main area that you want to be clean. So I'm gonna start the insertion site, and I'm going to work my way around, and then I'm actually gonna get up under here without trying to go over the same place twice with the alcohol. You can do that 3 times, you got 3 swabs, okay? All right, next for the ChloraPrep. There's lots of new up-to-date research about the ChloraPrep. What they have found that this particular device is best used with a friction rigorous motion, okay? You've already cleaned with alcohol, so we're assuming that there's not a lot of bacteria left on this area. See my mask falling? Should I pull it up? I can't, can I? Gotta leave it just like that because I'm sterile. I've had a buddy and say, hey, pull my mask up. I'm gonna leave it right now for now, but we know that I need to have my nose covered, correct? Okay, so I'm gonna pop my ChloraPrep And what I'm gonna do is very carefully start at the insertion site, and I'm going to scrub around. I'm not wanting to keep moving over the same area, but a good rigorous scrub, not scrubbing too hard to remove your line, but hard enough that you're getting a good friction with the ChloraPrep. Then you're supposed to allow this time to dry. So what you can be doing while you're waiting is coming over here. I'm gonna throw my ChloraPrep away. Okay, now I'm letting that dry. I think the standards say about 15 to 30 seconds, so you're gonna get your stuff ready. So now I'm gonna go in and get my Tegaderm. Here comes my good hand. I'm going to open it up. Well, usually the blue line is sort of center. Here, and these are very different. This is what you'll have in your kits. But what you want is you want to form an occlusive, tight seal around the line. My clamp right in here, so I'm gonna pull it out. So I want to see my insertion sites covered. I want to see that my dressing is completely occlusive and intact. And I want my lines to be straight so that when I'm ready to use them, I can come and access them just like so. At this point, is my sterile procedure over? Yes. My line is covered. Still got my sterile gloves on, but I'm no longer sterile at this point. So now I can fix my mask if I need to. I'm gonna come over here and I'm gonna get my label. I'm gonna date, time, and initial. And I'm gonna place it somewhere over here, away from the insertion site so that can be viewed. And place it there so that the next nurse will know when to address that. One thing I want to talk about real quick while we're on central lines is, let's see, the difference in the pressure gradients of syringes, okay? So something that you need to know in caring for any central line, whether that be this type of triple lumen central line, a port, a Groshong, or a PICC, which is a peripherally inserted central line that you might see in the upper arm, is that those lines are very small width bore, if you will. And just like sucking a straw with a milkshake, if you suck really fast, what happens to your straw? It collapses, which you can't see that's what's happening, but sometimes internally in these tubes, it's gonna suck the valve up and it's too much pressure, okay? So a lot of times, well, all times, if you need to give a small amount of medicine to this patient, you might need to draw up your amount in a smaller syringe that gives you more gradient lines, and then you're going to need to convert it because you will only give flushes and medications with any central line with a 10 cc syringe because there is less pressure in this syringe as opposed to the internal pressure of this syringe, the 3. So smaller, more pressure, bigger, less pressure. Okay, so when I'm going to attach my syringe, I need to be sure to hold the line here. And when I use my alcohol prep, do you see these little grooves in here? I always see people clean like this. Am I really cleaning what I'm about to flush into my patient? So if you'll see, when you insert that, what needs to be clean is this internal portion of this adapter, okay? So when you're going to use your alcohol prep, you need to get on top, really, really, really scrub all around those grooves, give it about 10 seconds to dry, and then attach your syringe to give your infusion. Another point I want to point out is when you're assessing patency of a central line, all lumens have to be addressed, okay? Your line is considered patent when you've addressed all lines. So I'm going to assess proximal, medial, and distal. I think that's right. Proximal, distal, medial. Usually they're defined for you. When I go to assess, the first thing I'm going to do is I'm going to try to aspirate, okay? And when I aspirate blood, I want to watch the blood come to about right here. I don't want blood to get into my adapter or into my syringe because what does that mean? It's contaminated. With their blood, I understand, but if that sits there, that blood, the fibrin sheets in the blood can clot. So we want to be sure that when we're looking for flashback, we see it quick right here and then we flush it back. And we want to make sure that these are cleaned out appropriately. Most facilities require that these end caps are changed every 3 to 4 days, depends on your facility. if you're going to change these adapters, this blue clamp has to be clamped at all times before removing this device. These have to be flushed and primed just like tubing. There's air inside of this adapter. So if all you did was put a brand new adapter on here, and now you're going to come with your flush and flush it, you know what you just flushed into your patient's jugular or superior vena cava? A lot of air, okay? That could cause an air embolism because we're directly looking at the heart, not a peripheral line that has a longer time to access the heart. We are working directly with the large vessels of the heart. Okay, so just keep that in mind. But you're gonna assess blood return, flush, move on to the next one. Blood return, flush, next lumen, blood return, and flush. So let's say that this port, for example, we didn't want to be too forceful, and we could not flush, and we could not aspirate any blood return. But the other two did. They worked fine. What I suggest is that you clamp off that line. We're going to document it as the proximal point because that's what's labeled here on the lumen itself. And sometimes you can get a sticker that might say do not use, or at that point we would probably notify our nurse, our instructor, and just know we're not going to use this port and then follow the proper policy in place. But if you still were to get blood return and able to flush the other two, our line is still intact. There's some sort of clot that is obstructing the flow of that particular port. So don't panic, just know that. Don't forcefully flush anything. Just note that and make sure that we check it with your instructor or with the nurse assigned to your patient, okay? Now, these lines with Grosjean and access port will also have these. They call them a PRN male adapter. There's different names. They'll have adapters as well. So when you're going to connect fluids, for example, find some. Let's say you want to start fluids using your CVL and you just assessed it and it looked really good. When you get your adapter here, you want to be sure that you're holding the adapter here and here for your lower lock. And then when you're disconnecting, don't hold back here because when you disconnect, what happens? You pull the adapter off. Now blood's pouring out on your patient, and also air is a risk for air embolism. Be sure when you are manipulating the lines that you hold the adapter and twist here, okay? You may see your facility uses the orange caps, the caps that have the alcohol-based stuff in them. Those, don't just assume that those are new. If you remove an orange cap, you still need to clean with alcohol before accessing that line, okay? So that's a good little tidbit on that. So then I would go and document all about my central line, but know that your flushing policies are the same. If you were to be given the opportunity to draw blood for blood draws, so a patient with a central line doesn't necessarily have to have a peripheral stick for their lab work. So they may be what we consider a nurse collect. If you're going to draw blood from this, of course you'll be with your instructor or your nurse to go with you. One thing to note is it's very important that you waste blood from the line. Most facilities require that you waste a full 10 cc's of blood. So that would mean I would aspirate 10 cc's of blood. That would go in the Sharps container. And then I would use whatever device your hospital requires you to use to draw the blood. Sometimes it's just another sterile syringe. And you'll draw the blood. And then the big thing is, after any time that you draw blood through this adapter, the adapter needs to be changed, like we just talked about. And we need to flush with 20 cc's of saline, if not more, to make sure that we are not leaving any residue of blood in that line and that it's flushing really well. Don't panic about that. We'll be with you all step of the way, but I just want you to know you always need to use a 10 cc syringe. And if you can, try to not aspirate blood into the adapter, but only see your flashback right up here in the line, okay? All right, thank you.